we started talking about exactly what to do here. And so the rest of this is a discussion about what you do with an SLDA, with an Ace and a Pascal.
Good evening, everyone, and welcome to SWAC on Murmur MD for November 2025. We have esteemed colleagues and fellows here today with Dr. Mark Bieniarz, Dr. Aidan Raney, and the rest of our team here with Zach, and our esteemed guest moderator. We have Dr. Sergio Garcia from Christ Hospital in Cincinnati, Ohio, who's going to share some of the Pascal registry data and some complex cases. So, Mark, I'm kind of excited about this. This is a newer technology. It's been around for about a year and a half commercially, but some of the challenging cases we have seen with this technology, I think, have started to push the limits and with pretty successful results. What are your opening remarks?
Well, I've just been really impressed with the anatomy that we can treat with the device. I've been really impressed with being able to salvage problems like we're going to see later, with the ability to just simply deliver the device in areas that previously would have been quite difficult. And we've been just learning about how we can adapt to this device as we do more cases. And so, I mean, I've been super thrilled and really just impressed with the performance of the device in so many different anatomical problems. So
Totally agree. And Aidan, for you, my friend, it's such a, it seems like a TEER when you say mitral TEER, okay, TEER, and there becomes another level of which technology, which size, and is it the right anatomy? How frequently do you use, Pascal or Ace for your DMR cases?
Quite a bit more, actually. It's something that we adopted. For me, I love MitraClip, so it took me a while to start to use it. So it's really not until this year that I really started to use it. And yeah, I've been really impressed. I mean, I think you'll go through what some of your criteria are, but I can tell you with, chords and complex stuff, it's really nice to have this, in your toolkit because it's really been a game changer, I think, for some of the complex anatomy.
Fantastic, fantastic. All right, Dr. Garcia, without further ado, my friend, let's dig right into it and see what sort of challenging cases there are that we can tackle with Pascal.
Sure. Thanks so much for having me, and I appreciate the opportunity to share some of these slides with you and also share some cases from our site. So let me first, for those of you who are not familiar with the technology, highlight some of the differences between Pascal and MitraClip. So this is a 3-catheter system. As you can see, there is a guide sheath, there is a steerable catheter, and there is an implant catheter. The combination of these 3 catheters really allow you to do movements in the 3 planes. On the left side of the screen, you can see the movement of the guide, swinging anterior, posterior. In the 2 middle slice, you can see flexing of the steerable, correcting a trajectory problem, and then advancing or removing the entire system can change your medial to lateral position, similar to MitraClip. And then on the far right, you can see the anterior versus posterior orientation of the steerable. The implant also has unique properties. There are a few that I would like to highlight. Number one is the presence of a central spacer. This is certainly a novel feature that is designed to accommodate the ERO and help with that reduced tension on the leaflets, and also have perhaps more effective MR reduction. The second feature that I would like to highlight is the fact that this device is constructed out of nitinol, so it's very, very much atraumatic and flexible. And the third one, which I think is very important, is the fact that there is only a single row of retention elements, unlike MitraClip that has 4. So this can, in my mind, lead to a more atraumatic grasping of the leaflets.
Hey, Santiago, actually, Tom, can you just comment on the whole concept of the flag and the flagpole? Because I think that's really important to highlight this device and its construction with nitinol. And Santiago, I'd love to hear your comments on the same thing. And really, it's the durability of the effect of the device too.
Yeah, it's a great differentiating feature. And I totally agree with Mark Santiago, where, we've described this in a paper called the flagpole effect. Imagine like you take a staple and you staple A2, P2, and if you have maybe P1 and P3 have some mild degeneration in an octogenarian, over time you may create such leaflet stresses and high afterload on P1 and P3, which already has some protein breakdown in an 85-year-old, that you may see residual or recurrent or worsening MR of those scallops that were relatively okay. So imagine you leave a flag out in the storm at night and you have it fixated on one side and it whips with the higher afterload. So that's one thing that we have described with other technologies. We have not seen it with Pascal and Pascal Ace. And I think because of the features you just described, it's very atraumatic, the clasping. There's also a flex component. You don't staple it closed with 8 clasps or bites or retention envelopes. What you do is you have a flexibility. So the nitinol flexes with the leaflets. Okay. And I think the afterload pressures are less and the stressors are left on leaflets, which potentially, to Mark's point, may prevent early breakdown of the adjacent scallops.
Yeah, and I think we'll look at the class 2D data. Obviously, it was not a huge randomized clinical trial. It was a non-inferiority design, but there are some clues there that may support what you just said in terms of efficacy and MR reduction. But no, I totally agree with those points you made. This device, as you all know, comes in 2 different flavors, the ACE implant and the P10 or Pascal implant. As you can see, some of the key differences, the spacer is wider and goes from 2 millimeters to 5 millimeters. And also the width of the overall device, the paddles, goes from 6 millimeters to 10 millimeters. So if you're thinking about potential indications for one versus the other, I think structures where you have a lot of chordae, I think, so you get close to the commissure, tricuspid indications, etc. I think there is a strong preference for the Pascal Ace device, and it's something that we have seen, at least in the early commercial experience in the United States. So let me start with the first case. All these cases have some degree of complexity of interesting features. This is the least complex of the 3, 87-year-old patient, bileaflet prolapse, and there is a component of MAD. You can see there is mitral disjunction. This patient, age 87, was felt not to be a great candidate for surgical repair. And I guess you can argue, why not TMBR? I think this would be an anatomy that probably would be considered for participation in any trial, but we felt that with this technology, we could probably tackle this and try to get this MR down to a mile. And so the baseline imaging is shown here. You can see bileaflet prolapse. There is no clear flail segment, but a lot of extra tissue. And this is what I was thinking, I would not fault anybody for thinking TMBR here. You have essentially MR across the coaptation line. And you can argue that this is not going to be an anatomy where you can get a consistent mile MR at the end of the procedure. Yeah. Any thoughts there, Tom?
Yeah, I mean, we'll go through the panel with everybody's, but I'd say, yeah, you have an indentation there, P1, P2, that's pretty deep indentation, thick and leaflets, as you said. A2 looks really thick and calcified. Yeah. And essentially, there's only 2 posterior leaflets. The indentation kind of separates P1 from the rest of P2, which is essentially a single leaflet there. So there's really a single anterior leaflet, you look closely, and only a P1 and a P2 scallop. So there's really only 3 instead of 6 scallops. These I worry about high gradients afterwards when there's single A1 leaflets and a single P1 or P2 leaflet. So those I also worry, besides the obvious redundancy, long leaflets that are billing with MAD1 looks like on the posterior side. So yes, a very complex anatomy on multiple levels.
Yeah. So Tom, would you put this in a TMBR trial, or would you try to Pascal?
Yeah, it's a good question. I mean, there's lots of logistical things about the TMBR trial, but this would not be a wrong answer at our center if we put them in, and you can put them in high life, Alta valve, you name it. M3 this commercialized next year. There's a little bit of medial MAC at P3, so maybe not M3. But there's lots of options here. And for valve replacement, for repair, I think you're very limited.
Well, and honestly, I'm a little bit worried about what you call an indentation and what I would hazard to say maybe a cleft.
Yeah.
I mean, it's you see the MR really focused in there too. So I would be a little bit hesitant to predict the success of TEER in this case.
Yeah. Well, very legitimate concerns. Aidan, any comments from you?
Yeah, I mean, I think on this one, I would definitely get a CT up front, try to see if they have a candidate for for alta valves, which we have. I'd be worried a little bit about that. That's a true cleft. And then also the long-term durability. I mean, there's a lot of tissue here. I've certainly had these cases with TEER where, even if you get
Yeah.
a reasonable result, a lot of times they come back a year later and there's a lot of MR when there's this much redundant tissue. So yeah, so I think I would, try to get them into the trial, and if not, then they don't really have a choice. And, I would probably do TEER and think, we'll be cutting these things out a year from now. But yeah.
Yeah, this is
Yeah.
this is like a yellow red. This is an orange case, Santiago. This is a
Yeah.
nice.
Yeah.
Yeah,
solid
no,
orange case.
agree 100%. And I think some of the things to discuss too, I mean, 87 and, if you can get them into a TMBR trial, that usually comes with anticoagulation and a different kind of long-term strategy. But that's why we gone, personally, I've gone a little bit full circle with this TEER, TMBR, and then I think with these technologies, I'm trying to push more the envelope on what can I repair more and more. So this was the case. I think the strategy was from the very beginning to commit to a 2-device strategy, even if you get a reasonable result with the first one, which is unlikely. I liked second device for stability. We started
It's
on
amazing.
yeah. We had good imagers. Fortunate to have 2 very good dedicated structural imagers. We started on the medial aspect of A2 P2. And this is the second device going in now, lateral to the first one. And some of the things that we do routinely is leaflet optimization. And even if I feel like I have a fair amount of leaflet, I like to do this maneuver where you essentially bias the device in the direction of the leaflet you're trying to optimize, come a little bit higher, lift the clasp, and then get more leaflet, get greedy.
And you're doing a great job of that with that posterior redundancy there, where
Yeah.
you see it really kind of prolapsing along the device in that first picture. And then when you've optimized it, you've reduced that posterior leaflet significantly.
Yeah.
I think for these anatomies, when you have bileaflet prolapse, I think this gives me an extra level of comfort that I have plenty of tissue, that I did my job, and that's not to signify that SLDL is never going to happen, but I think it will be less likely when you grab as much tissue as you can.
Yeah, I really wonder on these cases. I can see on the images the X plane here, the posterior leaflet. It would be really nice if you could get that all the way out to the annulus, and get all that tissue in there. And I think that's what would be ideal. And one of the things about Pascal is it's a little bit shorter, but a millimeter shorter than an XT. But I do think that there's some room for some of these devices to have longer clip arms, because this type of anatomy here, I really think you get a good result when you can get all the way out to that, the anterior hinge point, which looks like you have on both images, but that posterior side, if you could get that all the way out to the posterior annulus and get all that tissue in, then I think it would even be a better result.
Yeah.
Well, and it's a little bit hard with the MAD because it's going to be displacing this device no matter what you do, because the annulus is moving essentially.
I actually like the amount of tissue you have there.
Yeah,
I don't mind that little redundancy, because when you close it with the length of those arms, you're going to pull that tissue when you close it and close it. And I think, again, going back to the flexibility of this is so important. And when we optimize one side, we generally try to optimize the other arm. So if it's a posterior optimization, I'll just quickly rotate back anterior and raise it once, just to take any leaflet tension off of it, in case you had a little bit of torquing when you're pulling it to one side or the other.
And I think, I don't know how you evolve into this business of leaflet optimization, but I would say that 2 or 3 years ago with the other technology, people would feel very uncomfortable about doing these very aggressive maneuvers. When you grab one leaflet and swing very aggressively to the other side, concern about leaflet damage. And I don't think I was doing this routinely. I was doing this only as needed. And now I feel, honestly, I can get away with this and not have to pay a price for it.
Well, the single row of retention elements, biting deeper into the valve, you're much less likely to get that kind of laceration of the leaflet that I think everyone was worried about. And the same goes with repositioning this device multiple times. You're not going to be perforating, like a stamp, like the other device does.
You nailed it, Mark. Exactly right. So remember, the leaflet tip is spongiose, almost acellular tissue. The further you go to the base of the leaflet, it's more fibrotic, right? And having the retention element out there in the fibrotic area, you're less likely to be worried about these micro perforations that we do cause. When you're dropping this down on leaflets, whether it's a MitraClip or a Pascal, you're creating damage or injury. And some of those posterior P2s we see are paper thin. I get so worried about those tearing the leaflet and stretching the holes are causing an SLDA. So again, the flex of the catheter, the single row at the fibrotic base, not the spongiosa acellular leaflet tip, is so important. Excellent, Santiago.
Yeah, no, absolutely. So a quick refresher on optimization maneuvers, and this is maybe obvious for you guys, but just as a reminder, this is a sequence where you first bias the device in the direction you want to optimize, then you come a little bit higher, and only then is when you put the clasp up and then grab more tissue and then bring it down. And then, as you mentioned, then remove the tension, go back to the middle of the valve and proceed with optimization of the other one. And so, and some of the things I think you were alluding to, Tom, with perhaps why we don't see so much leaflet tear or damage when we do these aggressive maneuvers is are highlighted here. So there is a single row of frictional elements, and they are intended to capture the leaflet where there is more fibrous tissue as opposed to the free edge of the leaflet. So it's a design feature that I think is very, very favorable. So this is the final result. It's we have a small jets medial, in between, and lateral, but I think at age 87 and with that anatomy, I felt that we accomplished a goal here and took this as a win.
That's fantastic.
It really is. It's a beautiful result for what you had and the substrate of the valve you're working with. Let me ask you, what is your approach to clefts and indentations? Do you go right next to it? Do you go adjacent to it? Do you use a P10 versus an ACE? Maybe we can go through the panel with Santiago, Mark, and Aidan and kind of just talk through what is your approach or your strategy when you have a cleft or an indentation with Pascal and Ace?
So my first approach is to make sure that it is a true indentation, a true cleft, and not an imaging fake out. In particular, when you're using 3D, I would say that most of the time it's not real. It's a fake out it has no clinical value. When it's real, then I try to stay obviously away from it. Usually medial to it, and grow healthy tissue. But I would encourage everyone to spend time, if you have a good imager, making sure that you are reacting to a finding that deserves attention and not a fake out.
Mark, what are your thoughts?
I totally agree with that. And, really, a true cleft can worsen as soon as you place a device. And really, looking at it with the surgeon in the heart team meeting is very important. And then placing a device and seeing how it behaves. If it opens wide, you may want to bring it in closer or bring it in farther. I don't know that there's a programmed way of dealing with them, because it's a little bit unpredictable how a cleft or indentation is going to behave.
Yeah. Aidan, what are your thoughts?
Yeah, I agree with Santiago. I mean, I think a lot of times they're just fake. There's a little bit of relative, it's prolapsing on both sides a little bit. There's more tissue going up, and then you think there's a cleft there. But a lot of times when you put the clip there, there's actually tissue there. It's just a little bit lower. So it gives us appearance on 3D.
And it's just echo dropout. And I think this is a great example. This is a great example where this really proved to not be a cleft.
Yeah.
Right. I would agree with that. Did you think there was a cleft here, Santiago, or no?
No, there was no cleft.
Yeah,
it looked like there was on the 3D. So I think a lot of times just you got to get in there and put the clip in, and a lot of times they're not real. There's tissue there. So
fantastic result, my friend. Very, very nice
great
result in a very challenging anatomy.
Yeah, and this is the 30-day result. I mean, we have a single digit gradients. MR was reduced to mild, and patient is doing well.
Well, and I have to just highlight, if you look at the movement of this device, Tom, this is exactly what, if you have a fixed, non-flexible device in there, I mean, this is exactly what you talk about in your paper. I mean, it's going to be whipping the leaflet tips, unlike this device that actually, as it moves, it's going to be flexing and conforming to the leaflets.
Yeah. That flagpole effect when you have 8 rows of anchors on 85-year-old or 87-year-old tissue is going to cause leaflet injury to some degree. It really is. And I think this is important, especially in these octogenarians and enogenarians even that we're treating. This is again, Santiago, a beautiful result. And to your point, an 87-year-old guy trying to get him in a TMVR trial may take months, stuck on OAC for 6 months at a minimum. This is beautiful. I mean, this guy, you just changed his the trajectory of his life potentially.
Yeah.
Yep. Yeah. Yeah. So how do we get to this point where we have this device in the market? As a quick reminder, there was a randomized clinical trial called Class 2D. It was designed as a non-inferiority trial, so not a lot of patients. But all these patients with DMR were randomized in a 2-to-1 fashion to Pascal versus MitraClip. And these are the key results. When you look at MR reduction, 2+ or less, very similar, about 95% in the two groups. But when you look at MR 1 or less, actually you can see 79% with Pascal and it's about 69% with Clip. The study was obviously not powered to show superiority, but there are some trends here that are worth keeping in mind as you start, rolling these technologies to the marketplace. This is very encouraging for a first generation device that is really competing with a fourth generation device, right? So typically we don't see these kind of results. The patient that we presented, I think, would have been a perfect patient for the study. Low rates of adverse events at 30 days, 4.6%, and virtually everybody, 97% of patients had MR that was graded as 2+ or less as 6 months. So this is the trial that led to commercial approval in the United States. There is another arm looking at patients with FMR or secondary MR. They have completed enrollment, and hopefully we will have results next year, and then a commercial indication to follow. Second case, Tom, if you want me to proceed here with cases?
Yeah, please. This is fantastic.
Perfect. Yeah, so this is another case that was somewhat complex. 82-year-old patient, multivalvular heart disease, had a combination of severe AS and MR. We decided to treat the aortic stenosis first and then proceed with medical management of MR and reassess at 30 days. She had, MAC with a gradient of 5, not an AC anatomy. Hard to enroll in any TMBR trials when you have severe AS and multivalvular heart disease. We did the TAVR with a self-expanding valve. The procedure went well. About a year later, she continued to have symptoms, and DMR was severe, and so felt to be high risk for surgery. We decided to attempt MTR. And this is the anatomy. You can see there is a posterior MAC. There is a flail P2 segment. You can see that in the right side of the screen with severe, very eccentric jet of mitral coaptation.
And what I see here too, I can tell you when I look at these TEER cases now, is obviously the leaflet pathology, but the cords. Is it chordal rich? Where the location? Are the papillaries laterally displaced? Is there room to put a device in there? Are they calcified cords? So I think the subvalvular apparatus is so important, as important, I think, as a leaflet, substrate and architecture.
Yeah, that's a good point. We didn't talk about it in the first case, but I think most of us would agree this is an ACE case. This is not we don't want to put a big fat device. There's so much chordae and gradient of 5 to begin with. So
let me ask a provocative question with that comment. And this is for Aidan as somebody that is probably using more MitraClip than Pascal. Is there ever... I mean, I can't really justify, as I'm looking at this at the subvalvular anatomy, is there ever a case where you're going to say, oh, I feel like using MitraClip as opposed to Pascal? Because, just getting out of, these are thick calcified cords here that have risk for entrapment. Would you ever say, unless it's just a case where they're equivalent and you may choose that, is there ever going to be a case where you say, oh, MitraClip is superior here?
I mean, I certainly, I've been using it a lot this year. I'm probably actually using more Pascal now than MitraClip.
Okay.
And the main reason is I look at this, I see all those cords, and I'm just like, no way. I don't want to deal with that with MitraClip. It's been too many times stuck up in the cords, and you can get out of it usually, but it takes a long time, and then you go back in. And what I see too is, you do see that leaflet damage. One way or another, it gets caught in the gripper lines. You pull up, and now you got a bigger flail. So. Yeah, I think this type of anatomy, 100%, I'd be looking at this. I would be thinking about Pascal. Tom, we talked a little earlier too. Maybe you've got more experience with this, but it looks a little bit like a small valve to me. I mean, hard to say for sure. But when do you think about using P10 versus ACE?
That's a great question. We did allude to this a little earlier. This case, in small valves like sub 3, we generally go with a P10 because, again, that spacer is 5 millimeters versus the 2 millimeter that Dr. Garcia just mentioned. What gets me concerned in this image on the long axis view, as we just alluded to, it's the first thing my eyes go to, obviously the flail P2, but then the chords, how rich they are, right? How dense the chords are both anterior and posteriorly. I think I would still lean for an Ace here. I think, that 2 millimeter spacer may be enough. And also, the width. So the P10, the width of those paddles are 10 millimeters compared to 6 millimeters. So just the navigation in the chords is at higher risk probably with the P10 because of the width of that device. So I think a single Ace here, right? A2, P2 and nail that flail.
That's great.
Yeah, I agree. That was the procedural strategy. And I don't know, I was maybe overthinking this case, but I really would say to myself, I'm going to try to stay away from the MAC. I'm going to try to go anterior as possible when I cross and see where I go. And you can see what I'm struggling with here. I am ready to bring the clasp down and I can't. And I realized that I'm interacting actually with the frame of the evolute. This was an implant that was deep enough to require a pacemaker. It was not terrible, but certainly not 3-4 millimeters, probably closer to 7. And so you can see that I have both a trajectory problem and I have a position problem. I'm very anterior. You can see the shaft of my catheter here, very parallel to the evolute on the left side.
I'd be interested to see what you did, but I'm just looking at this and thinking in my mind, what would I do, Mark? And I'm looking at this. That's okay. I would probably go to a diamond, maybe not full elongation. I'd just probably go to a diamond. I would add some significant guide flex to stand it up, pull away from the aorta hugger. What I might actually do is actually try to do a de-optimization technique where I bias posteriorly, drop the anterior paddle, and then rotate back posteriorly. It's a challenging anatomy for sure. What do you think, Mark?
It is.
Yeah. Tom, I would add to that too. Like with MitraClip, I wouldn't do one of those things under the valve. Pascal is so nice that you can actually do those kind of movements under a valve like this with all these chords. Whereas, MitraClip, I'd be pulling out, come up, and try to go back up.
Santiago, you said it earlier very nicely and very eloquently. I think this device technology has really caused us to push the limits more and more. And we went from N-tier to TMVR because we made that change because there were potentially some subtle issues or concerns or maybe some minimal minor therapy gaps with technologies, and we rotated to valve replacement. Now you're seeing us swing back with Pascal to MTR. I think it was very nice and very eloquently put and spot on.
No. And so you can see the shelf of calcium posteriorly here. That's what I was trying to avoid, trying to grab healthy tissue and not the shelf of calcium. But I create another problem. So I did exactly what you just described. And by the way, I have fluoro confirmation that I was actually interacting with the frame of the evolute here. So the problem was very clear, and you can see how much MAC we have. We have the typical smiley face posterior MAC, trigon to trigon, and so we corrected these things. And first, let me see if I can advance here. And so with the diamond shape, exactly right. Fix our trajectory problem. We have to add some flex to the guy, get us off that evolute, elongated the device, and then come up to diamond shape. And you can see that on the right. And now once we have the diamond shape, I see that both leaflets are ready to capture, and then we went back to capture ready, and we were able to grab them.
That's beautiful. Aidan, you nailed it too, spot on, my friend. All that manipulation that Dr. Garcia just did, right? He was able to do it below the valve. And I think with the other technology, routinely come up above the valve, be in the HM and do those manipulations and get reorientated. So I find that we rarely have to come up off the valve to do manipulations with this technology.
So at this point, it became really a standard procedure. But we have sort of two enemies: the MAC on the back and the evolute in the front. And I think we were able to navigate that nicely and get a nice result at the end. So despite I think we started with gradients that were about 4 to 5, and they stay 4 to 5. And let me see if I can continue to play this. Really nice result. There is trace residual MR. We grab the bad boy. The flail segment is now inside the device, and
That's awesome. Mark, what do you think? Is this the therapy now if you have an evolute? Do you go right to a Pascal?
You know, if you can go back, I was thinking about this. I mean, this is a deep evolute. It's just such a bad situation. But what great handling of it. I mean, and you know,
Yeah,
I love the guide, the de-optimization that you referred to of really favoring in that
yeah,
posterior and really bringing out the anterior leaflet. It was really fascinating how the evolute was interacting with that anterior leaflet so much that
yeah,
it almost became invisible to you, and your
yeah,
manipulation of the device brought it out and allowed you then to focus in on it. You know, I think it was great.
Yeah.
But
yeah,
you know, I think that this absolutely with this again this complex anatomy, which was caused by the deep evolute, is an absolute for Pascal
yeah.
win.
And I
Fantastic
think,
case, Santiago. Fantastic case.
Yeah,
yeah,
great,
and this
great
is,
info.
thank you. But so this is really, when Tom has a nice publication in JACI Interventions looking at the early commercial experience with Pascal. And, you know, when you roll out a new technology, it's very important to look at the data because, you know, trials are done by expert operators and people that have a lot of experience with this technology. But the big question is how this is going to work in the marketplace. One of the things that we found in this analysis is that most accounts are actually not very experienced with Pascal, having done less than 25 cases in the first 2 years. And yet the technology is being used in the most complex anatomical sepsis. As you can see, 2 out of 3 patients treated with Pascal had one anatomical feature consistent with complexity, including some of the key things we already discussed here, MAC, a valve area that is borderline, bileaflet prolapse, and mitral stenosis. So about a third of these patients had actually 2 features of complexity like the one I shall show you. And despite that, you can see that.
Santiago, I'm sorry to interrupt. If you go back to that
Yes,
slide, one thing.
yes,
You have showed us 2 very beautiful cases demonstrating
yes,
Pascal. And if you look at that box of type of complexity, I think in 2 cases you've shown us, you had every
yeah,
single one of those complexities in those 2
Yeah.
cases.
yeah,
You had
yeah,
MAC, you had a valve less than 4, you had leaflet calcification, you had bileaflet prolapse in your first case, you had mitral stenosis greater than 4. I mean, that's at least mild mitral
yeah,
stenosis. You had the at least single leaflet flail, and you had tethering in the one first case. So I mean, as you said, this has really come full circle to M
yeah,
tier to TMPR back to complex anatomy with M tier and Pascal. It's remarkable.
Yeah.
yeah, yeah, yeah. And so these are the kind of results we're seeing, because you can say, yes, we're treating them, but are we getting the results we want? And the answer to that question will be yes. I mean, the majority of these procedures have been very successful. The most of these procedures actually have been done with ACE location. The most frequent location, as you would expect, is A2P2. All-cause mortality, about 2%. Half of that was cardiovascular. Very low rates of mitral valve reintervention, less than 1%. SLDA, less than 1%. And the MR reduction actually that we have seen is excellent. And so 94% of these patients had MR at 30 days that was graded by local sites as being 2+ or less, and 72% of these patients had an MR that was graded as a +1 or less. We have the same results for the overall cohort, and they are virtually identical. So complex versus non-complex anatomies. This is a great equalizer. As you can see here, improvements in functional class and KCCQ over about 20 points at 30 days. So without a meaningful increase in gradient. So I think these 2 cases highlight some of the things that Tom described in the JACC paper.
Fantastic, my friend. We have time for another case. I mean, Mark, Aidan. I mean, this is so exciting. I think we could do this all night. So
Yeah.
feel free to show your third case if you have it.
Yeah.
Okay, perfect. I'll do this one, and then we have time. I will turn it over to you. I know you have cases and things you want to show, but this one is, I guess I call it high DMR complexity, but I think all of them were complex. This patient had actually, ages 81, had a previous procedure at an outside hospital for severe primary MR. They struggle. They were able to place an NTW device. It was a commissural jet. But the patient continued to have symptoms. There was a severe MR after the procedure, and In fact, she was referred to us for consideration of a plug because the perception was that the first device was a little bit canted, and it was too small of an orifice to put another one. Had multiple admissions for heart failure between the first and the second procedure. And this is the baseline transesophageal echo. So this is a very commissular jet. There is a residual flail P1 segment that you can appreciate there, and a very eccentric MR. So comments, thoughts about this anatomy?
Aidan, when you see this, what are you thinking? I mean, can you squeeze in another device there? Is there really a flail there? Is this something that we can approach in standard MTEER, or do we need to put a plug in?
Yeah, I mean, first of all, I'd be a little bit worried about the orientation just because it looks so, you know, the initial clips, it's so eccentric. A little hard to see here, you know, there's some dropout, but yeah, I mean, I think in the past I would definitely be concerned about, you know, about putting a clip in here. But I think, yeah, I mean, I think with Pascal, this looks like it could be doable.
Mark, when you see this, you think a P10 or an Ace, or are you gonna consider an NT?
You know, I mean, I think that a P10 is not terribly reasonable because of the paddle size. I think that an Ace would be great in this position. I think that the deliverability with an Ace is going to be the best.
Yeah.
You know, the whole concept of plugging in the mitral valve is, you know, I've never done it. I have read very mixed results. I don't know that I would have even considered doing a plug in your app unless you absolutely cannot deliver an Ace. So
yeah, I've never done it either.
Would you consider here an NT or an Ace?
I'd try an Ace. I mean, I'm not terribly comfortable delivering a MitraClip in this area. I would be comfortable delivering a Pascal in this device, an Ace, a Pascal Ace.
Yeah, I think the differentiating point here for me would be that it's very commissural, as Dr. Garcia just showed. You're in the P1 flail. You're going to be in chords for sure, and I think if you got stuck below in this scenario, as Aidan was alluding to earlier, this would be a challenge to get out without interacting with the first device. So
I think it's high risk for getting stuck.
Yeah.
All right, Santiago, let's see what you did, my friend.
Yeah, so I did what I normally do, which is I try to cross this orifice with the device closed. And as you can see, we have MAC posterior and we have the device in the green box medial to the device, and it wouldn't go. I would try to advance it and it wouldn't cross. And so this is an Ace, and I'm getting frustrated with it because I really thought that this was going to be a doable procedure. And we decided, actually, my imager suggested to do what she described, the cat maneuver. It's just elongate the device in the atrium and see if it goes. And it's a cat maneuver. And so we call it a cat maneuver. We essentially proceeded to diamond first and then full elongation, and then advance the device in that form. You can see the MAC there and why we struggle, because we have MAC and then we have a canted device. But once we got under the valve, actually, this became a fairly straightforward procedure. So we did all our orientation under the valve. Once we were in a good position, we grabbed the leaflets, and you can see at the end we were able to grab that P1 flail segment and reduce the MR to, I think, only one.
That's great.
So yeah, we didn't have to. Yeah. You know, you didn't have to do this maneuver again, but I think people will have to do it. You will definitely face this problem at some point in your career. I think this is a common occurrence of having previous MTEER devices that are a little bit canted, and you have a residual jet lateral or medial in the case of a medial commissure, and this will be, I think, a good way to tackle those.
Excellent.
I don't know if I would have thought of that. Yeah, good job.
Excellent cases, my friend. Very high level advanced techniques and very complex, again, yellow orange anatomy. I mean, this really just highlights to me, Mark, you know, this is why this device has brought that circle full, right? I mean, we've come again MTEER, TMVR now, we're really pushing the limits, because again, this would be a challenging case to remove this clip and do a TMVR. You know, those cases have been done, but that's not an easy workflow by any stretch of the imagination. And so maybe give us your closing thoughts, Mark.
I mean, I don't even know if it's, I'm even more optimistic. I think that this is just within the tolerances of the device. It's not even stretching the limits. This is the utility of this device. You know, this device can be elongated and put into small positions. This device can be closed and brought into tight positions. This device can navigate around cords and be reshaped underneath the valve. I mean, it's pretty adaptable, and this is this device. I mean, you know, I think plugging this is pushing our limits,
Yeah.
and I don't think that's necessarily the right limit to push. This is the device for exactly this.
Yeah, exactly right. These
Great,
are the
great
differentiating
presentation, Santiago. Thank you.
No, thank you,
Excellent.
thank you. And the only comment that I would add, I mean, this is off-label now, but a lot of these features to me are very attractive to the tricuspid valve.
Oh,
When
yeah.
you think about elongation and getting
Yeah.
trapped in chordae and being able to do these aggressive maneuvers, I think it's going to be even more useful on the tricuspid valve, where imaging can be more challenging and anatomies can be tougher, and particularly whatever is below the valve.
Well, I like the teaser. We'll have to have you back
Yeah.
once the tricuspid's out.
Yeah.
Yeah.
Excellent, my
Great
friend.
presentation.
Aidan, give us your final thoughts on Dr. Garcia's cases, and then we'll move to Mark's challenging case.
Yeah, no, I thought it was great. And I really like your comment too about, you know, you've gone to TMVR and then back around again. I think one of the really impressive things about TEER to me is you show that safety slide. You know, how many people went to urgent open heart surgery, 0.1? I mean, this has
Yeah.
been you know, and these are not healthy patients. For the most part, they're surgical turndowns, right? And these patients actually, they do so well, even if they're sick.
Yeah.
And, you know, patients look at me like, are you sure I'm not too old or too sick for this? I'm like, you know, it's been, since I started doing this procedure, I've been very impressed with, you know, how well the patients do and how safe it's been. And I think this, you know, Pascal takes that up a notch.
Yeah.
Excellent. Well
Yeah.
said. Well said.
Yeah.
All right, Mark, we're going to tee you up here and show your complex case, and we'll see what sort of differentiating strategies we have to
All right.
move
Can you
forward
see
in
this?
complex anatomy. Yes, we can see it.
Okay, great. So the title kind of tells the punchline here, which is kind of intentional because the discussion comes at the end. It's an interesting case, in so much as I think that this also pushes the utility of this device. There's a manual for the Pascal devices that Edwards has that they don't share. But it's unbelievable. It's 204 slides, and if you guys can get it from your rep, I think it's really worth looking through because there's some jewels in there. And this presentation, part of it's from that manual, the PowerPoint manual, and there are a lot of solutions in there that I think that they withhold until you need to use them. And so it's a fascinating manual to just look through. So this patient that I'm going to present is a 73-year-old nuclear engineer. He was actually an assistant head of the Department of Energy, and he had 3 prior sternotomies. You know, which kind of speaks to I don't want him to be part of that 0.1% of urgent surgery. He had an ascending aortic dissection repair in '86, mechanical aortic valve replacement in '93, and then an aortic root replacement at Mayo in '94. And he'd had this like really rapidly progressive instability of his aorta. And he has this mutation that's associated with probably an aortopathy. And his daughter also has the same mutation, and she had a history of aortic dissection also. He also had this, as I was talking to him and going through the history, he had this aortic pseudoaneurysm at one of the suture lines that hadn't really been followed up on and measured 6.2 centimeters. And he was told by a surgeon to never let anybody operate on him again at Mayo Clinic. So this is what he came with. And now he presents with severe MR that was symptomatic, dyspnea on exertion when climbing stairs. He started using supplemental oxygen and had an increasing oxygen need after he had hip surgery and COVID. And he blamed it all on the COVID. And he had lower extremity edema that he blamed on the hip surgery that was not associated with the DVT. His MR on TEE, when I reviewed it, was complex with deficient posterior leaflet, posteriorly directed mitral regurgitant jet, and posterior MAC, and then kind of an atrial FMR, if you will. So he had this mixed pathology, and we planned on doing MTEER using two ACE devices. And you see this posteriorly directed jet with this kind of malcoaptation that's probably associated with his atrial dilation. And we like to do EROAs and measure them before and then measure them after to determine the success of the TEER. And he had an EROA that we measured, a functional EROA that is kind of the convergence of the jet. We measured that at 0.615 centimeters squared. The first Pascal Ace device went in, and we positioned it a little bit medially and appropriately. The imaging here isn't great. We have an imager that we work with 90% of the time. This imaging is good, I would say.
This is
And you
great.
see,
This is wonderful. Are you kidding me?
I had well, and I'm saying that you'll see why. I was trying to see the insertion. It looks great to me after I position it. It looks like there's a good tissue bridge here.
Yeah, I agree.
Okay, but remember, there's this very deficient posterior leaflet.
Yeah.
I'm not sure that this posterior leaflet has a lot of movement. This is the closed device here, and we're just looking at it and going, what is up with this? Could we have optimized it? We tried to optimize the posterior leaflet before releasing it, okay? We had a good tissue bridge here. You can see kind of a good tissue bridge on the right side, on the left side, but you see the movement of that posterior leaflet. There's the posterior leaflet pathology, and there's that kind of malcoaptation. We decided to release at this point after optimizing it. And when you're unsure of a leaflet, you're gonna release that leaflet first, of course.
The lock line. That's correct. Yeah.
Yeah. And this is why after we release the suture to that posterior clasp, we have an SLDA here. Again, it's a little bit hard to see in these images. I tried to select the best ones, but it was very, very, very clearly a released leaflet. And you can see it in that upper left. The upper right side. And it's clearly an SLDA. So at this point, we have lost posterior clasp control. We still have the suture to the anterior leaflet, and the device is still connected. We started talking about exactly what to do here. And so the rest of this is a discussion about what you do with an SLDA, with an Ace and a Pascal.
This is a beautiful case. This is really important, guys, because again, if you're concerned about one of the leaflets, anterior, posterior, to Mark's point, you remove that lock line first. If it looks unstable, you can then still bail yourself out. And I think that's also very differentiating with this technology.
And the unfortunate thing about this whole case is I was so freaked out by the whole thing that I didn't take very good pictures. So I'm sorry about that. But this
always happens.
I know. You never think, oh, this is going to be something great to present later. You just go, I just want to be out of here. I want to go to lunch.
Yeah.
And but this is an interesting picture because this is actually after I performed the maneuvers, and I performed both appreciated maneuvers, and we're going to go into these maneuvers, but I performed both of these and was able to actually get the device off of the anterior leaflet. And I used what's called the rolling technique, and that didn't work. And I tried that multiple times. And so I tried this guide sheath clasp capture to lift the clasp off of the leaflet and then grab it into here. And then we were able to retract it into the guide sheath, bring it out of the body. And I had a piece, of course, would have loved to have taken a picture of it too, but it captured a cord with the device. I was really worried that he was going to decompensate. He had worse MR, but he was fine. And it's very important at this point because of the manipulations and bringing the device into the guide sheath that you change out the guide sheath also to then finish up the case. Yeah. So then the rest of it's just finishing up the case. We positioned another Ace in a very similar position, but took our sweet time before releasing it, and then deployed a second one and had really just mild residual MR with nice stable position.
Quick question, Mark. Do you think the SLDA was related to having cord and not leaflet? Like
absolutely. Yeah. That's absolutely. I grabbed both. I think I grabbed cord and leaflet trying to optimize it well. And that is a risk then, because then it just actually didn't have anything. And so we talk about the benefits of that single retention element. But that is one of the risks of it, is you better be very, very sure that you haven't grabbed cord and have an incomplete closure of the device, because you have that one shot at grabbing something with a single row of retention elements.
Sure.
And so this is our final EROA, mild MR 0.15. And this is the result. So, really nice result. So let's talk about what you do here. So the decision driver typically is the type of implant. And, and I'd thought of none of this. Again, I just get freaked out with SLDs. This is all, to the Edwards reps credit, they were freaked out, but they then thought of what to do. And so you have these two techniques, and the whole goal and the benefit of this device is you don't have to abandon the device like you do with the MitraClip and just place a second device and have kind of this redundancy and possibly worse residual MR because you've abandoned a device. You can remove the device. So yet another benefit of it. The goal is to pop the clasp off of the paddle and then free the retention elements that are going to still be attached to the leaflet because they've dug into the leaflet. So you want to lift the clasp. So the rolling technique is used more often with the Pascal, and I think it's because you get a fulcrum with the paddle that's wider. And then the guide sheath clasp capture technique is then easier with Ace because it's more in line and can be withdrawn much more easily. And there's these other considerations that are caveats, which are the leaflet length that may limit how much you can actually pull on the leaflet, your transeptal puncture and the trajectory of your guide sheath, and then the actually position orientation of the implant, how commissural you are, and if you have torque on the device at all. So we have the alligator roll technique, the rolling technique. The objective, again, is to raise the clasp and then roll the device to disengage the retention elements. So you open the implant, you slowly advance the implant using the leaflet to lift the clasp, and then you elongate the implant to increase the separation between the clasp and the paddle. And then you roll the device after you've raised that clasp, pushing against the leaflet to bias the captured leaflet to actually prop the clasp open. And the whole goal is to remove it from the leaflet that you're still attached to at this point, okay? And then if you have to retry it, you want to note the neutral position so you're not torquing on the leaflet that you have continued to be attached to. So you want to look at that catheter, at the implant catheter flush port, to know your neutral position. And then you simultaneously, the roll technique is the retract and rotate counterclockwise or clockwise to bias the device away from the leaflet with the raised clasp that you've achieved by pushing on the leaflet. And then if you're unsuccessful, you return to the neutral position. And this is kind of a bench model of how to do the technique. It's actually really cool. I mean, so they've raised the clasp, now pushing on the leaflet, and then they've rolled it away. And it actually behaves this way.
Mark, this is remarkable. This is why we do Murmur MD with SWAC, because this is going to be syndicated in the library for these guys. The next time I get a potential SLD, I'm going to pull my app out and go Murmur MD, look at Mark Bieniarz, and I'm going to say, hey, Zach, where is it at? He's going to text me. I'm going to be able to rescue this case. This is phenomenal.
Well, thanks, Tom.
Or you call Mark too. That's the first thing I would do.
Well, I mean, or you just download this manual. These are images from that manual that I was talking about. These are embedded in the manual. They don't let you like copy them, but you actually can take the images out, and this is hidden in there. You just have the fluoro images.
That's
so Mark, in simple terms, I mean, I never had to do this, but I always ask myself, why we do it the way we do it. I get the same answer. If you're not sure, you can rescue yourself. But in simple terms, this technique, the first one, the rolling technique, the device still comes to the guy. And in the second one, the guy comes to the device.
Precisely.
That's what you did.
That's absolutely true. And, and of course, if your guide sheet, as you can see in this model, in the upper right, you can see that the clasp is lifted up there, and then they're able to roll it off. And that's kind of what you want to see. I have teenagers playing video games in the background, so if you hear them yelling, that's what's going on. Sorry about that. And so yeah, the guide after the device is off can be advanced forward to help to capture the device.
Yeah.
All right, so then we have the guide to the device rather than the device to the guide. I love how you said that, Santiago. So in this, you're going to telescope the guide sheath down on top of the implant, and you're going to try and use the guide sheath to lift the clasp up. Okay, so you're going to ensure that the paddles are fully closed, and that the sliders are fully advanced, and that any extra guide sheath flex is removed. You want to make everything coaxial, and then you align the guide sheath flush tube to the steerable fin, again, making everything coaxial. Unlock the sheath stabilizer. And this is, when you put it into words, it's kind of a little bit complicated. All you're trying to do is slide the glide sheath over everything else and use the glide sheath to pop the clasp. Okay. So here's an example of that. So we're going to take it, and this is advancing the guide sheath over the steerable and then over the implant, and kind of reducing the flex on the steerable there, so that the guide sheath is then moving smoothly on top of the steerable and then up to the implant to use the guide sheath to then, and aligning this, right? So that's what that maneuver was, aligning it to the device and then using that to, okay, so that was just getting it up to it. Let's see. And then capturing the clasp with the captured leaflet into the tip of the guide sheath. But you're going to bias the guide sheath towards the captured leaflet, which we saw on that, and then simultaneously advancing it to and retracting the clasp until the clasp tip is actually inside the guide sheath. So that's going to be shown here. So that advances it further and then allows you to lift the clasp off of the leaflet. And then the whole thing should then just come off, okay? And you're going to retract the device then. Because of the flexibility of the device, it should then come off once you've put that device between the clasp and the paddle.
So the device comes out in a closed configuration. You don't have to extend it.
The device comes out closed, exactly. And it's extending here as you're retracting it.
Got it.
But it came off closed, but but you've captured that clasp, and then you're opening it in order to separate the paddles from the clasp.
Got
it. But then it's going to come, you're going to close it around the guide and bring the whole complex out.
Yes.
So that's what we're doing here. So it's coming out of the valve and back into the atrium in a closed fashion. All right, so SLDA and Pascal, when still on, when one clasp is still controlled, can be dealt with using these two aforementioned techniques for implant removal. The implant doesn't need to be abandoned like it does with MitraClip. When there's questionable insertion, I think probably the most important thing of this presentation is remove the suture from the questionable leaflet. After you've optimization, like we talked about earlier, is so important. But remove that suture from the questionable leaflet first, because then we can deal with it with this technique. So thank you, guys.
Fantastic,
awesome.
Mark. That was awesome, man. That was really, really valuable. And again, I'm glad this is syndicated. We can get it on Murmur MD. We have our fellow's been itching to show a case here. So if we got about 2 minutes, maybe we can quickly go to an alternative access case, and Santiago, we can then wrap it up in about 5 minutes. Dr. Mo, do you have your presentation ready to go? Perfect. Okay. So Aidan, while we're loading up here, again, another differentiating feature of this technology, hopefully you don't have to use it, but if you have to, I feel very comfortable now that this makes, being pragmatic, it makes sense that we can have the ability to do that. What are your thoughts?
Yeah, no, I mean, I know the MitraClip device so well, and I've taken them apart, like screw by screw. I'm not really there with my knowledge on Pascal. So yeah, it's good to know that this is an option, and I know why they're telling me to do it. But again, I think Mark had a great point, is the more you know these devices, the better it is to get yourself out of a jam.
Yeah. That manual is so good. I mean, I can't tell you guys somehow. I have a copy of it now if you guys want it. It's really
Edwards, you're probably breaking the Edwards law somehow.
No, they actually made sure it could be released before I did this. So
Oh, good. Yeah, I'd love to see it.
yeah, it's pretty great.
Yeah, love it.
You know, I was amazed at you know, just doing this technique and the limited damage to the valve too, which
Oh,
you know, it really makes you realize that you know, even when you're manipulating on the leaflet, how you're not really damaging it with this device because of the flexibility of it.
That's fantastic. Okay, we have Dr. Mo here, is our PGY structural heart fellow. He's going to share an alternative access
Pascal case.
Can you guys hear me?
You're
Yeah.
echoing a lot.
Hear me now?
Yeah.
From the
Yeah, let's do that. Yeah.
okay. So hello everyone, thanks for having me today. I'm gonna present a case that I've done with Dr. Waggoner recently.
Can you guys hear us okay?
There's a little feedback. I don't know if you're in the same room or something, Tom, but you might want to close one of the mics.
Yeah, let me close mine up here. There you go. Go ahead.
Can you guys hear me now?
Yeah, perfect.
Yeah.
There you go. Okay, thank you. Again, I'm the structural fellow working with Dr. Waggoner. Gonna present a case we've done recently of transjugular Pascal in patient with inferior vena cava occlusion. So she was 76-year-old woman, severe degenerative MR and tricuspid regurgitation, presented for elective TEER due to progressive exertional dyspnea with New York Heart Association Class 3. Again, her cardiac history and past medical history included degenerative MR with chronic heart failure, both mixed systolic and diastolic, persistent atrial fibrillation on apixaban. She did have history of AFib ablation, which affected in some sort our procedure course, as I will show later, hypertension, hypothyroidism, and mild cognitive impairment. We brought her first time for MTEER, but after we gained access, femoral venous access, we could not pass the guide wire. And then we tried bilateral on the other side, and then we did the venogram, and we did find there is a total occlusion of the inferior vena cava with extensive collaterals. So we decided to abort and to plan to bring her with the transjugular access. Her TEE pre-procedure showed severe degenerative mitral regurg originating from a calcified restricted medial P2 and P3 leaflet, accompanied by severe tricuspid regurg and marked by atrial dilatation with a preserved left ventricular ejection fraction of 55%. And here the clip that showed severe MR. Sorry, can I make this one bigger so you guys can see it or not? And there's the BICAM view, which again showing severe posterior directed jet with the tethered and heavily calcified posterior leaflet, as well as thickened, and there is a shelf of MAC also at the anterior leaflet. EF again preserved, and there is a severe dilatation of the left atrium, as shown in this video clip. Again, this is the in-fast mitral valve view on 3D showing the severely tethered and calcified leaflet of the posterior leaflet, as well as thickened and MAC of the anterior leaflet. So for access, again, we use right internal jugular access. We use ultrasound as always for the access. And we use something for the setup of the table because we are, again, coming from jugular is different from the transfemoral access. And I put here the image here just to give you an idea about the setup of the table. So once we got transjugular access from the right side, actually, Dr. Wagner and me, we went on the left side of the table here at the head. So I see for interventional cardiology where Dr. Wagner stood up, and we have our cardiac anesthesia and the imager standing to the left of Dr. Wagner, and here's the shield, and here's the II. And the Edward reps, two of them actually were standing on the side. The monitor was across from us, so we can see our fluoro as well as our TEE. As far the anesthesiologist, he was standing on the right head side of the head of the table. So thus make the workflow very smooth and efficient as far as getting access and the manipulation during the procedure. For the transseptal and septostomy, because she had a prior AFib ablation, her septum was heavily calcified, and it was very difficult actually to gain transseptal access first. And most of the time of the procedure, actually, we spend it trying to get access, the transseptal puncture. That was on the top of the trajectory when we come from the top. Actually, it is superior and inferior. So when we try to push anything, it will prolapse with the vector of the force down. So that added the more challenging to get a transseptal puncture. We do have experience prior from our watchmen, transjugular watchmen. We did find that to get effective tenting and transseptal puncture, we need a catheter actually with excessive bending to get perpendicular to the septum and to enable the puncture. So that's why we did not use more standard catheters for the transseptal, and we did start with the large curve Visigo catheter that enabled the perpendicularity with the septum and to get the puncture. Then again, because it was very calcified and very hard to puncture, we did use mother-daughter technique with the support of the JR4 and fine cross system, and and then we use a stato and electrocautery to assist with the puncture. After that, we did swap the wire and we used the Safari. We position it again in the LV support because from our experience before, you don't have favorable rail if the wire in the LA or in the pulmonary vein because you are coming from the top. So there will be acute curve in the wire if you position it in the pulmonary vein for the exchange. And that will not give you favorable rail and it will not help with the pushability. So to establish a good rail to push the Pascal sheath, we decided to position the Safari wire in the LV, and that helped a lot. After that, actually, we used the dry seal 26 French the transjugular for the system. Here I made some cartoon here using the images, still images. So as you can see, again, coming from the top, you can see the dry seal and then through that the Visigo catheter, and there we again the stator wire inside the fine cross and the jugular to get us enough support to achieve the puncture, septal puncture. Here on the actually we did use both. 3D was very helpful to see the trajectory of our catheter, and here from the top you can see the SVC, um, and again the pushability, and you can imagine the prolapse when you try to push anything because of the direction of the force is going downward. So that's why we wanted excessive bend in the catheter, which was provided by the Visigo. Um, then as far as the positioning, we did advance the Pascal sheath from the right atrium across the posterior after we did balloon septostomy again using Armada balloon. And then the sheath tip was stabilized in the mid left atrium actually for the device delivery. Um, for the navigation, again, we use what's called reverse cobra technique. Thus, when you come from below from the transvenous, usually to gain height using the Pascal system, we flex on the system, then we clock it. So it appears like cobra head. and to gain the height. Here, when you come from the top, actually, we have to do the reverse cobra. So actually, to redirect the sheath and the delivery catheter toward the mitral valve. So we did extend instead of flexing of the guide, which we usually do if we come from below, we did extend here instead of the flexing. So here I have images here. So after we advanced here, you can see the trajectory of the clip is going anterior and lateral because we are coming from the top. And you can see it also on the 3D here. Then Dr. Waggoner did with the guide, and he used excessive turning of the catheter, almost 360 here you can see, to make the trajectory going towards the mitral valve plane. And it worked actually. After that, we were able to line up with the mitral valve plane and to cross and to check our trajectory and our position and to check our grasp. And we were successful in the MR and significantly. And here you can see actually dynamic steering of how Dr. Waggoner was trying to extend actually the guide and the steering is towards the mitral valve. Again, I play it for you again so you can see.
It's pretty remarkable. Or go on mute for a second. This lady was turned down by surgery twice. We tried to go femoral quickly. The wire wouldn't go, so we did a venogram that was occluded. It was well collateralized, rich collaterals up through the, or parallel to the IVC and epigastrics. Had surgery here a second time. Surgery said no, still high risk, and then they were going to go to palliative. And the lady was actually fairly viable. So we had done a number of Watchman transjugular cases and had tricuspids as well, actually, replacements and repairs. And we thought this would be a reasonable option with Pascal. I don't think I would try this with other technologies. But Mo, go advance the slides. One more. But pretty remarkable if you see the follow-up outcome. The gradient was only 5. She did really well. Shunting was not an issue. It was all left to right. And the patient still knew this was 4 or 5 months ago, and she was going to go to palliative. And since then, she has moved to California, and I think I gave her this guy. His name's Dr. Aidan Raney or something like that.
Obviously,
follow up, but it's quite remarkable. So the take-home message is that there is a viable option for transjugular. We've learned through our LA closure experience, use a sheath like a dry seal that's a size or two larger as support because the neck structures are pretty soft and there's a lot of ability for it to not have support. So we love using a dry seal. We use an 18 dry seal for LA closure and a 26 for mitrals, and gives you more support. And then the transeptal using a Visigo, which is an angulated, like an Angelus essentially, that's really has the ability to curve because the transeptal is the most challenging. And then finally, the ability to clock and counterclock is the inverse from the femoral axis, where from the jugular approach above the diaphragm, when you clock, you go anterior, and you counterclock, you go posterior. Well, go back to the slide where you show the X-ray and the echo combined.
Hey, Tom, I have one question for you.
This just shows, Mark, to the point, go back one more. The ability of this technology, we've talked about it from a leaflet, apposition, and a repair strategy. I think the ability of this catheter itself is also quite differentiating, where you can use this to navigate in very tortuous anatomy. If you look from, at number C here, how we have this thing literally almost nearly a 360-degree loop with the delivery catheter, I think is very remarkable.
It's awesome.
Tom, the guy sheet, so you have the dry seal on the right side.
Would love to hear your comments.
Yeah, no, it's an awesome case. The question for you, so the dry seal is on the right side, and then
no, we got him.
Yeah,
We
Tom, I think.
Can you hear him okay?
Yeah, I think maybe. Can you hear me now?
Yes, we can. Perfect.
Yeah.
No, awesome case. Thanks for sharing. The question relates to the location of the sheet. So you have the dry seal on the right side of the heart.
Correct.
And then the guy sheet, the Pascal, is on the left side.
Correct.
Okay. And all the maneuvering you did is not much with the dry seal after you did the transeptal puncture. It's all with the Pascal steerable.
That's correct. Yep. The dry seal gives you just support in the neck. So we did Watchman without just with the true TEER delivery system, and you just lose a lot of support in the neck. It's a very soft structure. It's not like over the femoral head when you're pushing down, you have support.
Yep.
So just using a dry seal was one.
No, I get it. This is brilliant. Brilliant. Great
Yeah.
case.
Yeah.
That's great. Tom, so you stand on right versus left. So basically you're standing on the left side.
Correct.
What are your thoughts about going right versus left, IJ, for something like this?
I think the trajectory is going to be easier from a right jugular. So we stand on the right side of the neck, do the transjugular puncture with ultrasound, rotate around, stand on the left side. And if you're right hand dominant, it's easy. You're there just doing the same nomology. Everything is just backwards and inverted.
Got it. Wow.
And
Awesome.
so what you do is you come in and you flex up. You're actually flexing up to get your height, and then you flex back down. So you do steerable, flex, guide and steerable, flex up, and then you rotate it, and then steerable, flex down. Then you just extend it. Everything else is very similar to what you're used to.
Awesome.
Hey, Tom, what are you going to call this technique?
I don't know, just transjugular Pascal, you know.
You got to come up with something.
Yeah,
Yeah.
the most challenging though is, as Dr. Mo alluded to, is that it is getting the transeptal, and that's
Yeah.
the same issue we've had with any left-sided. So we've done mitral replacements, I'm sorry, tricuspid replacements and tricuspid repair, TEER, very easily straightforward through a jugular. Watchman, challenging, but once you get through the transeptal, pretty easy. Mitral's challenging. Once you get through the transeptal, again, relatively easy. The key is
Yeah.
putting the wire, the safari wire, through the transeptal, always doing a septostomy, and putting the safari wire into the LV apex.
Yeah.
You cannot go up in the pulmonary vein, it'll prolapse out into the IVC. So once we do for Watchman, we come in with the guide. Once we hit through the transeptal and have before we cross the mitral valve, we just break the dilator, pin the guide, pull the wire and dilator back, and then flex it right across the annulus of the valve. So you can skim across the valve. You actually never go through the valve for most of these techniques.
What about using VersaCross, that system to cross from the neck?
You probably could, honestly. You know,
Yeah.
we're a poor community hospital, Mark, that you don't have the finances for something like that. So we use the old BRK1 safe set.
We're poor. We have two of them. We have two of them sitting on the shelf waiting to be used. So
Oh, that's fantastic. Well, excellent, guys. I know we're well past the time, and I want to thank all of you. I'll get final comments. Aidan, let's go through Aidan, Mark, and Santiago, your final thoughts on Pascal and complex anatomy.
So impressive. Santiago, thank you so much for being part of this. This was great. And I learned a ton like I always do when I'm on here. I'm just impressed. I'm impressed with the device. I'm impressed with you guys. So thank you.
Excellent. Aidan.
Yeah, no, I agree. I learned a lot from you guys. You've been doing it longer than I have. Took me a while to kind of take the leap into Pascal, but I've been super happy with it, especially in chords, commissures. I think it's a great option to have in the toolkit. So appreciate learning from you guys.
Excellent, my friend. Very good. Santiago, give us your final closing thoughts.
So I think the TEER will remain, I think, the standard of care for mitral for foreseeable future. And I think, you know, as much excitement as I have in DMBR, I think these device iterations are very important to expand the pool of patients that can be treated without anticoagulation, without screen failures for the most part. And I think it will remain the cornerstone of mitral transcatheter therapies.
Awesome.
Excellent, my friend. I totally agree. And guys, thank you so much on behalf of SWAC, Murmur MD, and Dr. Santiago Garcia, and our colleagues, Mark Bieniarz and Aidan Raney. Thank you so much for joining us on November's edition. Thank you so much.
Thanks, guys.
Thank you, guys. Bye-bye.